Welcome to Good Sex at NYU, a podcast about sex, relationships, health, and mental health in a sex-positive space. So if you're looking for sometimes serious, sometimes funny, and always sex-positive discussions, then you're in the right place. I'm Danielle Elliman, Associate Director of Sexual and Relationship Respect Services at Counseling and Wellness Services. I use she, her pronouns.
And I am April Fellers, a nurse and sexual health educator at the Student Health Center. I also use she, her pronouns. We are two white, cisgender, heterosexual, female-identifying clinicians, one with a medical background and the other with mental health experience, who seek to create a space that is inclusive of all identities, backgrounds, and perspectives. Today on Good Sex at NYU, we are joined by our colleague Grayson Chao from the Physical Therapy Department at the NYU Student Health Center. Grayson Stephen Chao is a professor, anatomist, media contributor, and writer. After graduating from NYU's Doctor of Physical Therapy program, Grayson worked in the area of sports orthopedics before arriving at Memorial Sloan Kettering in 2010, where he served for over 5 years. There, he developed a deep interest in oncology rehabilitation, which continues to be his primary field of authorship. As an industry expert, he has also been quoted in large health publications such as Men's Fitness Magazine and Under Armour. Currently, Grayson is manager of the PT department at NYU Student Health Center and recently authored the textbook Oncology Rehabilitation. He is also on faculty at the College of Staten Island, directing their anatomy laboratory and teaching anatomy and biomechanics.
We are so thrilled to have you on the podcast.
Thank you for having me. I am thoroughly excited to be here.
Yeah, and so physical therapy may not be something that people instantly think of when they think of good sex, but I think it's something that we should be taking into consideration when we think about sexual health and relationship health as well. So hopefully people will be able to get something really valuable out of it, because I think that, we use our body to have sex and relationships. So I think it'll be really interesting, especially for me. I'm excited. Mm-hmm. So can you tell me or tell us a little bit about the work that you do, and how you address sexual health concerns that arise as a result of any kind of physical conditions that come up?
Yeah, I totally agree. So it's really interesting. And as I was kind of prepping and thinking about what to talk about today, I kind of came onto this idea that I found that good sexual health is kind of distinctly non-sexual, right? Mm-hmm. So much of our sexual health has to do with physical factors, biological factors, how we feel about ourselves. Mm-hmm. So these emotional and psychosocial factors. So much of our well-being really that seemingly feels unrelated really plays a lot into our sex lives, mm-hmm. right? So
preach.
So from a physical therapy standpoint, we could kind of approach it two ways, right? On the one hand, there are specific isolated injuries or dysfunctions that affect the sexual system and sort of that genital urinary system. So that's one way to approach it. But the other way to approach it is taking a step back. Physical therapy really operates on our entire system of movement. So we want people to operate, move, and function as best as possible. Okay. So given that, and a lot of the way we approach physical therapy interventions is through the lens of what is functional for that person. Mm-hmm. So pulling away from the specific dysfunctions, what you find is that, okay, how can we allow this person to function as best as possible to achieve their goals? And just sex is just another part of that. So mm-hmm. Everything from physical fitness to mobility to even just personal empowerment. So if you feel, and we'll talk, I feel like we'll get into this, but mm-hmm. If you feel strong in your body, if you feel positive in the way you move, that's an area where physical therapy is not so much in the past, but increasingly now getting into. And so that's kind of the broad umbrella.
Yeah, I think that's really, really great. I think most people don't think about their physical fitness when thinking about sex. But yeah, I mean, if you want to have enjoyable sex, you might need a little bit of stamina, might need a little flexibility to,
Yeah, or just liking your body, like, getting undressed and being naked, right? And so you don't have to beat the society standards, but like, how are you feeling in your body? How are you moving in your body? Like, what kind of pain is there? If you're not feeling like you have comfort in your body, then maybe there's activities or things that you can do to help improve that side.
Yeah. Well, I know you said the second half was about dysfunction or sexual health issues, or what are some common sexual health issues or dysfunctions that PT can address?
For sure, yeah. So in general, I think 2 to maybe 3 most common in the world of like pelvic health physical therapy that we'll encounter are going to be any kind of pelvic pain. So, for people with vaginas, that is, any kind of pain with penetration. People with penises, it's some of the painful ejaculation or receptive intercourse if you are identify as male and have sex with male identifying partners. And then the third, which in our NYU community probably a little bit less likely, are going to be any kind of postpartum issues. So a diastasis recti, which is a separation of the central line of the abdominal muscles. So that's one that's common, and weirdly related to that, just back pain, like back pain after having a baby.
I was thinking that. Well, not just that, any old time, like as you get older. So maybe not something our students like necessarily manage, but like back pain in general can really be an inhibitor. Mm-hmm. Yeah. And so, how do you address some of these chronic pain issues when it comes to, mobility, and what kind of like things do you do to help with those issues?
Yeah. So again, we can kind of explode PT interventions into sort of 2 broad parts. So there is the one side, which is the structural, biomechanical, physiologic side. So any kind of like movement related dysfunction. So tight muscles, tight ligaments, loose ligaments, anything needs to be strengthened, anything that's too stiff needs to be sort of relaxed or overstretched. There's an assessment that's involved. We identify any of the areas of impairment, and then we attack those elements of impairment. So that's the physiologic side. In the last decade or so, we have started to incorporate the biopsychosocial model of pain, which like, you guys are aware of this, right? Mm-hmm. Okay, so right, the relationship between how we feel, how we perceive our bodies, but also how we perceive pain. So again, as time has gone on, physical therapists and rehab professionals have gotten more in tune with intervening on, okay, how do you feel about movement? How do you feel about where your life status is? What is your stress level? And so there's this other side of encouragement, empowerment, and building confidence within like a person's body.
But I was gonna ask, like, how do people know when they need to come? Because you're talking about too tight, too loose. How do people know? Is it about just how I feel in my body and kind of just this internal assessment of something doesn't feel right and maybe I should seek out physical therapy, or kind of how do those go hand in hand? Or
yeah, well, in the area of sexual health and pelvic health, this is a little bit of a sore subject for me because most people don't know. And when they should know, they convince themselves that they don't think that they know, right? So, because the answer is most oftentimes they're coming to us when they have I don't want to use the word debilitating, but when there is a dysfunction or limitation that is so pervasive that they've really lost their ability to interact and interface with their community. So, you know, I keep having accidents all day, and I'm at the point now where like I really can't get outside, and I'm really miserable. So I went to a doctor, and it turns out whatever, I have some form of incontinence, right? So oftentimes they're coming to us with a true societal limitation or some sort of really functionally limiting pain.
Yeah. I feel like I'm thinking about this in context of the barriers, like people struggling to understand the healthcare system, people not really having all of the best insurance, not knowing what insurance is covered. Like, do you find that there are other barriers for people accessing your services?
Sadly, yes, absolutely. I mean, you know, physical therapy as an intervention is not necessarily the most well-covered practice. And within the way our healthcare system works in the United States, a lot of the ways that PT practices can keep pelvic health services afloat is, unfortunately, they tend to not take insurances because they don't want to sacrifice the time, the attention, the really deliberate and focused care that a lot of these cases need, right? I want to be able to give all of my time and attention to you, to hear your story, to appreciate where your life is, what traumas you've gone through, which, you know, God willing, you haven't had any, right? Like, so that takes time, and physical therapy is a time-based practice. So there's always this push and pull. So yeah, insurance is reimbursement. Like many people who need pelvic floor rehab, they just can't afford it.
Yeah. And how does that look in the student health center as far as like the services that are provided? Like, do you find that people know about the services? Do they get like a lot of your referrals from within the student health center, or how do you get a lot of those referrals?
Yeah. In terms of physical therapy specifically, or like pelvic health?
I mean, both and like.
Right. I mean, because right now with the student health center, we're working towards starting like a pelvic health program, but it's like not a thing that we offer at the moment. So like, you know, but yeah, I mean, today people are becoming more and more savvy, so they're going out and they're seeking out the information and the services that they need. So you know, thankfully, you know, there are like social media and all that kind of stuff. They can search, they can go on groups, and usually it's like a word of internet, I guess. Is that a way to put it? Right, a word of internet referral. You know.
Mm-hmm. So, are there people that you see currently at the student health center that, you know, obviously we can't be seeing for pelvic floor PT specifically because there isn't necessarily somebody there, but do you have students currently that come with, maybe not, they don't come in specifically saying that they aren't having good sex, but they're, you know, kind of digging a little bit deeper and realizing that whatever they're there, whether it's a mobility issue or some other kind of issue that is impacting their sex life, and kind of how do you integrate that into their treatment plan?
Yeah, well, this definitely gets to the point that we were kind of starting on, right? Which is, as you dig, you find that it kind of flows both ways. So they may be referred for a low back pain or a hip pain, but as you explore, there is a sexual health ideology. So, you know, right, I am a gay male identifying person. I have sex with my partner receptively, and you know, there was a period where they suffered from like a rectal prolapse, right, where the tissues of the rectum kind of come loose, and then so that in turn creates a system of tension within the pelvis. So their back pain is one of a sort of like sexual, it lives in the sexual health space.
Mm-hmm. Mm-hmm.
So that happens like not all uncommonly. If I can have the opportunity to talk about other areas of health and go, well, hey, like, what is your bathroom schedule look like? What is your, we do kind of get some elements of like, yeah, I do have accents when I sneeze every once in a while. So, it definitely goes both ways, where a seemingly purely orthopedic case has these sort of like, arms of sexual health pulled in.
So if there's not a specific person at the student health center that can do pelvic floor PT, are these things that you refer out, or do you work on some of the orthopedic stuff and then refer out if the pelvic floor issues continue?
Yeah, in general, it's a referral out because you want that dedicated experience. It's a special viewpoint, it's a special lens that you treat through. So I want them to have like the full value of that skill set to bear. If there are instances where it is something that we can address within the office, we try. As a tangential point, like there's this, again, back to the point of like sexual health being decidedly unsexual sometimes. A lot of the perception of pelvic rehab is made like an offshoot of gynecological treatment, which is, internal, it's intimate, and it's not always that way. Like there are hip muscles that double as pelvic floor muscles. So you can work on certain things externally. So by and large, we refer out if we can manage it. Like we always will try.
Mm-hmm. And as the non-medical person in the room, can you explain like a little bit more about the role of the pelvic floor muscles and why they're important to overall health? Because I think when I think of pelvic floor, I think instantly of my body and like my female body. And I heard you say earlier that the importance of no matter what, body you're in, that it's really important to us. So I'm wondering if you can explain it as like the non-medical person who's like, what?
Sure. Yeah, that's one of my favorite subjects. So what we talk about as the pelvic floor is so I have a pelvis in front of me. If you think of the pelvis as like this open bowl, you have a pelvic inlet and a pelvic outlet. Some people will call it. Then you have the brim of the pelvis. So the crests of the iliac bone are what's called in anatomy as a false brim. So there is a true pelvis, which is housed within this sort of bowl between the sacrum, the tailbone, the pubic bone, and the pubic symphysis in the front, and then this contour within the pelvis called the arcuate line. This arcuate line is the brim of the bowl of the pelvis. So then when we say a pelvic floor, the pelvic floor is the bottom and the floor of this bowl. That's also, but because this is continuous with the pelvic cavity, right, you can think of your abdominal cavity as like this can or a box. The common example is a can. I think of it as a box because you have your abdominal muscles, which are a wall. You have your diaphragm, which is the top of the box, and then the pelvic floor, which is the base. So I like box because I always think of that time that I was trying to move house in the rain, and because I was 18 and not the brightest because I'm 18, I put all of my boxes of books on the soaking wet ground. So as soon as I pick up this box, it is not good. Like the whole box falls out, but also more crucially, like, and if you can picture, right, the bottom of the box falls out, but then the box collapses in on itself.
Okay.
And so there is this structural closure that your pelvic floor creates. So yes, it has a role in bowel and bladder control, but it is more importantly a very, very critical pelvic and trunk stabilizing structure.
Okay.
That's really
helpful
visual.
Like image. Also, just a little TMI as you're like doing that. I'm doing like my Kegels right now. I'm like, ooh, is that something that's helpful? Like, are there things that you can share that I can do to help, like, increase that muscle and make sure that it's a strong, healthy, like bottom to my hopefully not wet box.
Yeah. Sure. I mean, you know, there is a dark underbelly to the Kegel exercise.
Okay.
But leaving that alone for the moment. Absolutely. So the pelvic floor contraction or the pelvic elevation exercise, yes, that is tried and true. It's very, very classic. That's a great way to directly strengthen. But again, pulling away, the pelvic floor muscles are just other core muscles. And hopefully one takeaway, listener, that you may have is
Danielle.
Yeah, right. But don't think of your pelvic floor as separate of just your core. Because yes, like the abdominal muscles, they have a great publicist. People love looking at them.
They love the six pack.
Yep. Looking at you, Chris Evans, like, so, there's this, so we equate core with abdominal muscles, but core is really trunk stability. So it's your diaphragm, it's your abdominal muscles, yes, it's your low back muscles, it's your hip muscles, and it's your pelvic floor muscles. So within that frame, any core strengthening that you do is going to translate into pelvic sort of floor like benefits. So do your planks, do your squats, do your lunges. All of these elements are going to, granted tangentially, still affect like that pelvic floor health really is just health.
Mm-hmm. Grayson, I just got really sad because now I have to go to the gym and
well, I will tell
planks.
you, as someone who did pelvic floor therapy after delivering a baby, part of my PT was literally just laying on my back and deep breathing as well. The diaphragm is part of that. And so that's part of it too. Just lay on your back and deep breathe.
So I don't have to go do some planks right away. I can work up to the plank.
Yeah. Like level 1 is laying on your back, staring at the ceiling and breathing deeply.
Is there, I think a lot of people with thinking about Kegels and the need to strengthen the pelvic floor, but in learning about pelvic floor PT while pregnant, I had also heard that sometimes your pelvic floor can be too tight. And can you share kind of like how somebody might know without, going to a PT is probably the best way to determine that, but is there any signs that people can see for themselves to know whether their pelvic floor might be too tight or too loose?
Yeah, it's so truly, it is hard. It is difficult to really feel clarity in understanding if it's too loose or too tight. So really your signs they tend to be any kind of painful, let's call it transit through your pelvic floor. So any kind of voiding, moving your bowel, voiding your bladder, just pain on those elements, painful penetration. Again, people with vaginas, painful intercourse. If you're doing, if you're a receptive sexual participant. Okay. You have to drill down a little bit, and there's a little bit of understanding. So for one, if you are voiding and you feel like you have to exert a lot of effort, like I can't go fully unless I really, really, really push. So that can be an indication that you are having to use your breath to overcome the resistance from a very tight pelvic floor. Because a lot of people who so a common form of incontinence is urinary frequency. So gosh, I don't drink that much water, and I'm just going to the bathroom like every few minutes, it feels like, right? So that can be that your bladder is not filling, that there is a weakness in your retention of urine, and so you're emptying all the time. However, that same urinary frequency can also indicate that you are not voiding your bladder fully. So you're retaining, and basically you're just peeing a little bit, and then it's filling up again. So you have to go again. You void a little bit and go again. again, that is partially due to the fact that you are unable to overcome the pressure of a very tight pelvic floor. So so any kind of like transit pain, increased frequency avoiding, and increased effort avoiding.
All right, I've just self-diagnosed myself with too tight. But are there other things that you can share with us, maybe lifestyle changes or habits that we can employ that might help us to improve our pelvic floor health?
Yeah, absolutely. I mean,
we're New Yorkers, we sit too much. Is that a bad thing?
Yeah, well, so sitting is a bad thing, but again, that's the nice thing about kind of where we started, right? Which is pelvic floor health is just good health. So having a healthy mind and body. With regards to a healthy body, it really is, right, don't sit too much, try to get enough exercise. You want to try to incorporate some kind of resistance exercise into your general wellness plan. Then using that as my little, like, I'm forcing a segue here.
Please.
but right, like, we do know that physical activity does impact our stress levels. It is a positive stress reductive effect. It increases self-reported measures of happiness and well-being. So that turns into just being an overall happier and less stressed person. And trying to really have good practices in terms of your own mental health. Identify your stress, identify your triggers, know your triggers, have healthy stress reduction methods.
I think that's a really important, that, like, kind of what you're saying, that it's physical therapy, medical care, like mental health. It really is the full package, and we can't. And I think that they're all related, right? Like, somebody that says I have urinary frequency might go to the doctor and think, oh, I have a UTI, when it really is potentially a pelvic floor issue, or it could also be a psychosocial issue, of just being too anxious about something and not wanting to pee their pants. But
I mean, is there a chance that I could overdo if I work out too much? Like, does that have an impact? I'm trying to get out of working out so much, but like, I think, like, we have some people that can take this to like an extreme, and so, like, can there be negative implications on doing too much at the gym or doing too much?
Sure. I mean, going back to that same sort of, like, excessively kind of tight and spasming pelvic floor. Yeah. I mean, overstretching, over exercising can absolutely, the tension you put in is not always the tension you can take out. Right. Mm-hmm. So if you are training very, very heavily, definitely the intense athletes, the intense, and I would say I lump dancers into that category. Dancers are athletes, no matter what anyone tries to tell you. They are elite level athletes, and all of the lifestyle elements associated with these types of intense activities and intense careers. Yeah, for sure. I mean, balance is everything.
Yeah, definitely.
So we talked a little bit about some of the conditions that somebody might seek pelvic floor therapy. You've mentioned vaginismus, or pain with receptive intercourse. What are some other issues or ways that PT can help with pain during sex, or difficulties with arousal or orgasm?
Okay, sure. Let's just take those into two pieces, right? So, altered states of arousal, either hyper or like too much or too little. There are some elements. There is some interesting and convincing evidence around the impact of sort of circulatory and muscular health as it pertains to sensation. So it is important to have healthy pelvic muscles for example, like people with vaginas, right? As you reach a point close to climax, right, there are these involuntary muscular contractions. Those muscular contractions can influence the degree of pleasure or sensation within the sexual activity. So having adequate muscular tension and contraction is going to serve the pleasure of sex. So again, it really does come back to that sort of fitness. Similarly, there's some evidence to support that increasing circulation into sort of like the pelvic region is going to improve the quality and endurance of one's arousal. I hate to keep coming back to this, but again, like physical fitness, if like just as I'll share my personal experience, right? As a cis hetero male, right? Like, and male identifying, like for me, if the feeling of physical weakness, of smallness, that is my iteration of feeling unattractive and unworthy and unvaluable, right? So, having a general sense of fitness and well-being, that improves your attitudes around your personality, your personhood, and then so like your arousal may be facilitated. But even without the gender rolling and gender identifying of that elements of that, right? Just feeling physically fit enough, like you mentioned this before, right? Feeling physically fit enough, feeling physically healthy enough for sex. Absent that barrier, like you don't have this barrier for arousal. So that's the arousal piece. In terms of pelvic pain, fortunately, that's a much easier road. It's not necessarily simple, but it's direct. Whatever's stiff, we try to loosen. Whatever's tight, we try to stretch. Whatever's weak, we try to strengthen.
And how does that look for, you mentioned briefly, if somebody has experienced trauma before? I know that there can be a relationship between somebody who may have experienced sexual trauma and vaginismus, or like pain during sex or pain during penetration specifically. And so going back to your biopsychosocial model, like how do you work with someone that may have experienced trauma and now is coming with the either wanting to have a better sexual pleasure experience, or just not wanting the pain with penetration? Yeah.
Well, I think you two might be a little bit better equipped to deal with some of that than I am. But and again, just we kind of introduced, but like trigger warning for the audience, we'll be talking about traumas and ideas around assault. But like the physical reaction to any kind of trauma, your cortisol spikes, you become tense, you get very, very nervous, and then you become overly tense. If you already have a degree of tension, that can ratchet up your tension. So there are instances where we may need to call in like a lot of psychiatric, psychologic, like sort of like other support first. Trust building is super, super huge in that space. So a lot of times we may do a lot of work externally or just through exercise, even sometimes just with our voice, where just kind of like step back from the room and go, okay, let's try to visualize relaxation, kind of depending on wherever that person is in their trauma journey. There needs to be time because I'll just gender this just to keep with the statistics, right? So like a female person is far more likely to be a victim of assault. And so where that iterates is if there's any penetrative trauma, right, there is a stress reaction to that tension. So there are techniques that are external and internal that can reduce that tension, but the act of treating it can also be triggering. So we have to judge those things against each other. So like I don't know, I ask you guys first, like truly.
Yeah, and I've definitely worked with some of our students who've experienced that, and sometimes it is, doing some grounding exercises, building that trust, having good communication with their providers, and going slow, pacing themselves, and figuring out like what are some things that you can do on your own to sort of work up to touch. Maybe it's touching in the body, maybe there's more physical things that they're going to be doing in therapy where they're, still feeling that tension. And so a lot of times it is slow or at a pace in which like the person feels comfortable with, but definitely incorporating both, like we've been talking about the, mental health and the medical combining together to collaborate with the client and go at the pace that feels like safe for them to move forward. And I've had people who've gone through physical therapy and still, are struggling because maybe it is more on the mental health side of things where we're still sort of working like, oh, we've gone through physical therapy, we've done dilators, we've done all these things, and there's still pain, there's what's happening, and so it can be a different journey for every person.
Yeah, I mean, just to reflect the question for you all, right? Like, so in that instance, and we don't have to get into specifics of the person's case, but so in the case of a person who has had physical therapy, who has had a trauma, and then let's say not gotten full resolution, like do they go back? Like what do they say? How do they describe their physical therapy journey to you within that?
Yeah, I think that, I've had different folks. I'm thinking of someone who had more dyspareunia, who had like more external vulvodynia, but one person that's coming to my mind is, someone who had a really, great physical therapy experience, had a lot less pain, but there's still some pain remaining. And it was, well, now what? Like, I thought it would just be gone. And so I think figuring out like what kind of underlying trauma have not uncovered yet, like what kind of additional work maybe do we need to do, but also how are we feeling with the partner that you're engaging with? Right. And so I think it's still like, even like after this person maybe switches partners, like how will we feel there? It's like developing safety in that relationship and making sure we have levels of control and that we're continually like talking about some of these things and making sure that like, oh, okay, we thought this was addressed, but like the thing is that with a new partner, with a new situation, something might resurface. Yeah. Right. And so this particular person had a really great experience. She got a referral from the Student Health Center, for outside PT and had a really great experience. So it wasn't anything to do with, I think. And I think that she also had, is there a surgery for vaginismus? Some kind of, anyway.
If there was some sort of physical tightening or like physical structural issue.
So I think she had some, like she had physical therapy, she had a surgery, and then she also like came back and like, oh, there's still some pain that's happened. So she had a lot of different steps in her journey. Not everyone goes through those same exact steps, but for her it was like, several years in the making.
Yeah. And I think also like, I'm sure that you all do this in PT, but we talk a lot about trauma-informed care and just like going in with the assumption that anybody could have experienced some form of sexual trauma in the past, and really that of like asking before you touch somebody. And physical therapy is a very hands-on approach and modality, and so I'm sure that's just part of your all's work.
Yeah, it is. At some point we can talk about practitioner selection, and that's, I think, one of the real two hopes for I really take it upon myself to try to get the message out to just physical therapists in general, because physical therapy traditionally always lived in the realm of like sports medicine, so, and that's changing a lot, but it's not necessarily what we're going to encounter all the time, and it's easy for physical therapy to forget physical therapists to forget. And, when, yes, like trauma-informed care, it needs to be a big thing, but also just appreciating that. And there's a reason why the PT profession, just to pull the curtain back a little bit, there's been a lot of effort to revise the way the professional organization speaks about our profession, what we do, and we're trying to incorporate this consciousness of the whole body system. But I definitely want everyone to at least approach physical therapists and say, hey, like, are you trauma informed? Because when they kind of go, oh gosh, maybe I'm not so sensitive to how I approach my patients. Maybe it's more careful in the way I organize my practice. That's really how, like, that's one of the forces that changes cultures.
I think we should ask all of our doctors that, or all of our providers, because it's super important.
It's not a crazy thing to say, or just at least kind of, like, address it or have it be a conversation piece.
Yeah. Well, I guess I was so sure in my conversation or my statement there because I know you and the way that you are. And so I guess assumed that everybody working for you would be the same too.
Well, how would someone pick a good provider? Like, aside from asking that question, like, what are some things that you might suggest that folks look for in a provider for physical therapy?
Yeah. I mean, it's a basic. I mean, some of the basics are just sort of transcend any kind of region. So obviously you want to know their experience. You want to know that they've been practicing within your needed space for, a good amount of time. Although I tend to be, when you really want to see kind of what clinicians have been doing to try to keep current, like if they've been like writing or going to courses and things like that. I tend to find that like the real sweet spot is like kind of like that 3 to 15 year kind of practitioner, because like they've been in long enough to have some experience, but not so long that like everything has changed. So definitely experience, dedicated training in the area that you need. But then also just like attitude and fit, on the Good Sex podcast. So like, this is an area where you really want to feel good about who you're working with, and all of the elements. And like if you go into their space and they put no thought into the way their space looks, is it welcoming for, people with sort of like sexual and pelvic sort of complaints, like, that's something to be at least inquisitive of, let's say, and their attitudes, the way they communicate. Those of us who do this a lot, like, we really care about it, and we put a lot of time and effort into making sure that our patients are getting what they need. So if it feels half-assed, maybe that's something to think about.
Can you talk a little bit about someone who may have a permanent mobility issue and comes to physical therapy and may or may not bring up wanting to improve their sexual pleasure or sex in their life? Like, how do you help people with mobility issues to improve their sexual pleasure?
I mean, it's an interesting question. So it's definitely a consideration, and if we are, and I say this truly, if we are fortunate to encounter those individuals who need assistance in that way, it's a really kind of like lovely thing, because anyone who has a baseline mobility disorder, either just congenitally or acquired, in the nicest way, it really puts you face to face with, a lot of the bigger questions of your personhood. So it again comes to kind of like the various elements to it. So within movement disorders, like there's such a wide spectrum, but the very, very short version is, you look at what they're working with, you see what they have, and then you just try to give them as many strategies as possible to to make it work. So teaching positioning, teaching creative ways of mechanically setting yourself up so that you are as advantaged as possible to be mobile. If someone is limited in a greater capacity, so let's say it's a person who has a higher level spinal cord injury, right? We will teach positioning, partner positioning, so the partner can position them in the most optimal way where they the individual and then their partner are both as comfortable, as literally physically supported and as mobile as possible. And you just kind of roll from there. We are very, very pro adjunctive device, I guess is that's a real euphemism, but but
I was like, can you explain that a little further?
Yeah, but we are very, very pro straps, supports, tables, toys,
get me to the sex shop.
Yeah, truly leave no stone unturned. A perfect example is if a person doesn't have the use, or if a partner doesn't have the use of their hands, right? A sleeve or a vibrator, it can be it can be the key unlocking piece to their entire sexual relationship with each other. So yeah, and I think that's the nice thing about rehab as well, is that we're already used to splints and braces and belts and supports, and so you throw you throw in something else with some toy at the end of it, it's really not that big a deal.
Yeah. Throw in a harness, throw in a swing, throw in a whip, we're fine.
Yeah.
I mean, do you encounter people that struggle with some of the embarrassment and talking about the sexual component, if they're struggling in one area or the other, and are you able to help them feel a little bit more comfortable sharing about that aspect?
Yeah. Yes. So it's been interesting, and I've definitely meditated on this in the last year or so, just from various experiences that I've had clinically, and also not in the clinic, less. And again, it goes back to that point of, if they've gotten to me to talk to me, they've already asked around, they know what they're looking for, and they've asked office, hey, I have a question about this. Are you comfortable talking about it? Are you experiencing dealing with this, whatever, this area? And so if I'm saying yes, then they're going, okay, great. And then they're really ready to share. So in this age of better education, that doesn't come up as much. However, certainly I've also had the experience of working with someone for 4 sessions, 6 sessions, and then they kind of go, hey, they kind of I kind of want to have I have a question, right. And I kind of want, so yeah, there's definitely still a reluctance. And the part that really bugs me about it, I'm going to go on a rant, but the part that really bugs me about it is that they think they're going to make me uncomfortable. I'm that sucks.
Yeah.
Because my only goal is to help you. Yeah. And the fact that whether it's my fault or not, that you feel like you can't share, it sucks.
Yeah, I think it speaks to our history and either medical providers or how people respond to some of these things in general. That's part of the point of the podcast, really, is to destigmatize it. But when we do talk about it, how are people reacting? Are they getting judgment? And so are they used to that judgment? Are they used to that, embarrassment or getting negative feedback? So I think it, probably isn't you. It's probably all this history that they're bringing into that room with them.
Yeah. And I do find that there's a lot of because and even outside the sexual and pelvic health space, right? There's a lot of patient shaming. Someone will come and say, "Well, yeah, my neck hurts because I know because I have bad posture and I carry my bag too much." And sometimes I go, "No, it's just because you started law school and you're incredibly stressed out. Your posture is actually fine." So I think a lot of people feel just that kind of like patient shamed, like guilt of personal responsibility, too much personal responsibility.
Internalized shame.
Yeah.
Is there any benefit to you bringing up, in like being the first one to bring up somebody's sexual pleasure, or does that feel like if somebody's coming to me because they have wrist pain, that's a little awkward and I'm not going to just bring this up on the spot?
Well, if it's a person with wrist pain and I start asking about their sex life, that might not go over well. But it definitely depends. I mean, just to revisit an example, there are definitely times where if there's an evaluation where I feel like it's pertinent, obviously the importance of sexual pleasure is not necessarily a big part of it, but I do go, hey, did you have you carried a child to term? Do you have any GYN complaints, right? Just today someone asked me, my back pain's been really flaring up, and I think it's because I am having my period. And I said, okay, sure. When was your last transvaginal ultrasound? When was your last gynecologist visit?
Yeah.
So there's definitely value to bringing it up, sure. Contextually, sometimes it's not the easiest for the PT, but I like it to be, I'd like to be easier.
Are there any
sure.
screening tools? Because I have a friend who had some back problems and was looking for a PT because there were lots of reasons. One, couldn't get out of bed, but also couldn't have sex. And so one of the screening for one of the PTs that they went to was how is this impacting your sex life? And he was like, non-existent, zero. And so when he ended up meeting with the PT, he was like, well, what would you like that to be?
Mm-hmm.
I was like, well, I'd like it to be more than zero.
Right. Yeah. I mean, a lot of our functional scales within physical therapy, so they just look at overall function.
Okay.
So there's a scale called the Oswestry Back Index. So it has sexual function as a part of it. So yeah, that's an element that we can pick out. Yeah, definitely.
Yeah, just one of the things I remember from his experience. But
the question that I was going to ask before was going to be the difference between PTs and OTs, and is there a benefit to somebody seeing one over the other?
Yeah, loads of benefit. So the delineation between PTs and OTs is a little bit fuzzy.
So OTs being occupational therapists.
Yes,
correct.
Thank you.
Occupational therapists and physical therapists. They both live in the rehab space. The coding of physical therapy is really sort of like general overall function. Occupational therapists serve to fill a much more specific transition. So they have very specific and dedicated goals. So I want to be able to move effectively in my kitchen. I want to be able to, I'm unable to use my hand to cook effectively. So what are the adaptations and interventions that can serve that? And incidentally, with regards to occupational therapy, because their focus is so much more granular, absolutely there's a benefit, because first of all, their training is a little bit more directed at specific adaptations. So like if there is an adaptation for someone's sexual life, like they're going to have more of a vernacular. They have a better dictionary and toolbox for those specific things. But they can also fill that gap of being able to specifically address hand function, positioning function, and then home adaptations, crucially.
That's great.
Yeah. So yeah, it get everybody involved.
I know you didn't want to go down the Kegel route, but
no, we can talk about Kegels. Yeah.
Should people not be doing Kegels on their own without an evaluation by PT, or what should or shouldn't people be doing?
Yeah, what's your recommendation as I continue to do them over here?
Well, it truly is. If you know your body, yeah. So With muscles you can always up train or down train. So Kegels are in general going to be like, if I had to blindly put money down on a bet and say, are Kegels good or are they going to be bad? I'd put money on good. I think the big thing that I want everyone just to be conscious of truly is, like, it's not right for everybody, and you just have to know why you're doing them for. If you are, like our student, generally healthy and without complaint, doing Kegels a few times, a few rounds a day, probably shouldn't be an issue. And just the muscular contraction element of it can engender relaxation also. So it's not to say that contracting a muscle is always going to be increasing of dysfunction, but it doesn't solve everything. And don't just go on Reddit and go, oh, great, Kegels fixes everything, and just throw it at everything. Yeah.
And if you were a woman, say in your, 40s, you're worried about, urinary health, like being able to like not, wet your pants later on in life. Is it helpful for that? I think that's what I've been sort of told, like, oh, well, like you have to like do these because like later on in life as well, you want to make sure like, and again, it probably goes back to pelvic floor stuff, but like I'm wondering, because I've just always been told that. I'm like, oh, it's not just for sexual health, but also because like you don't want to like be incontinent later.
Yeah, I mean, so again, it's the same. It really is the same answer. Okay. Like, do people trend towards weakness as time goes on? Yeah. Well, I don't want to say weakness. It pathologizes it. Like, but like, does muscular strength decrease over time? Yes. Do muscles get smaller over time as we age? Yes. But the specific flavor of incontinence, that is not, necessarily age specific. Like, it really is. You want to be. It's different strokes for different folks. You really have to know like what your issues are, what your physical landscape is. So on balance, I would actually probably say no. Like it really is like truly in almost every dysfunction you can imagine, physical or otherwise, like exercise truly is, it's just general fitness, like a well-balanced cardiovascular and resistance training program is the easiest and most direct way to impact all of these things, right? You can't OD and refills are free. So that is your best strategy to maintain all of those kinds of health, including sort of incontinence. You really only want to intervene in these ways because it's the same thing like doing like just in case bathroom visits. Like, you should void when you need to void. You can train yourself to want to void more frequently than you have to. Like in this area, like there is such a thing as too much of quote unquote a good thing. So no, I would say just cross that bridge when you come to it. Okay, so you're telling me I can't do the easy out and just do Kegels. I have to go to the gym. There's a theme here, Grayson. Yeah. You keep telling me. But the other thing is like try, for everyone too, like in regards to physical fitness, make it fun. Yeah. It doesn't have. I play volleyball twice a week, so I think that's that. If you can throw in a little bit of like, one round of like, if you like yoga, if you like swimming. I run twice a week and I go to the gym twice a week. I do it. You do it. Albeit reluctantly, it seems. I do it, but I really have to talk myself into it. But aren't you glad you did it once you finish? Yeah, but I don't get like the high. I'm like, whew, I'm glad I did that. Now I can go eat something good. Yeah, but that's the thing. Like you're always glad you did it afterwards. Yeah, no, for sure. Yeah, but
I have learned a lot in this conversation. Yeah. Where can people find you if they want to get connected?
Well, to find me, just come down to the Student Health Center on the 4th floor. I'm tucked back in the corner of our physical therapy suite. But anyone who wants any other resources about this, you can always go to aptapelvichealth.org. So all one word. And aptapelvichealth.org also has a directory of certified pelvic health physical therapists. So and it's broken up by state and by specialty. So there's a whole direct that you can find anywhere you need it.
Great, and we'll put that in our show notes so folks can link to that in their off time.
Yes, please.
All right, thank you so much for being here.
Thank you so much. I've had the greatest time, you guys.
Yeah, it's been
Thanks,
fun.
pals.
If you have questions about the podcast or anything we talked about today, please feel free to reach out to us at goodsex.podcast@nyu.edu. This email address is monitored during business hours and may take 3 to 4 days for follow-up. We are definitely open to critical and thoughtful feedback, as we didn't cover everything in this episode and might have said something that was inaccurate or that had a negative impact on someone. If you have questions about your sexual health and are an NYU student, you can connect with our Student Health Center sex expert at sexpert@nyu.edu or schedule an appointment through the Student Health Center portal. Look at our show notes for additional information and resources, including organizations, articles, books, and videos.
If you have urgent mental health concerns, safety issues, or you are worried that someone might have caused harm to you, or that you might have caused harm to someone, then you can contact NYU's Confidential Wellness Exchange at 212-443-9999. Chat with them using their mobile app or email them at wellness.exchange@nyu.edu. For anyone, NYU or non-NYU listeners, you can call the National Sexual Assault Hotline at 1-800-656-4673, the National Domestic Violence Hotline at 1-800-799-7233, or the National Mental Health Hotline. Simply dial 988 from anywhere in the U.S.
Thanks for listening, and tune in to our next episode where we continue to talk about good sex at NYU. Subscribe to the podcast to hear all of our quickies and interviews with NYU community members. Thanks to our content contributors for this episode, Bernadette Kerr, Alyssa LaFosse, Dr. Dominic Baini-Amisa, Zoe Raguzios, and to our health promotion team, Anna Genova, Jenny Mellum, Parade Stone, and Arna Dixit, and to Gotham Studios and Karen Ortman.